So this is Rachel Gilbert. So another Rachel, Rachel too, also called Gilby. She is one of my friends from Rice University. We went to school together. She is a bioengineer, just like I was when I was at Rice. Only she actually works as a bioengineer now, which is pretty cool. So she works for the Rice 360 program at Rice University, which basically takes these medical technologies and kind of converts them or improves them for developing world settings. So they're low cost, very, very simple, very, very robust solutions to medical problems in very, very rural and very poor parts of the world. So she's here to talk to you about some of the technologies that they're working on here at Rice and some of the technologies that she's been working on as an engineer there. So she's really, really awesome, really, really cool person. So listen to this, if you have any questions, she's more than happy to help you guys out.
Yeah, and you can interrupt me during, or just shout out. I don't care. Okay, yeah, so as Rachel said, I work for Rice 360, which is an institute at Rice University that really focuses on global health and involves students in designing technologies. So we're both involved a lot in our undergrad designing these technologies. So we focus on giving medical technologies to low resource hospitals. So here we have a pretty good healthcare system, even though sometimes it's costly, but we take a lot of things for granted. Like a lot of us have access to really cool medical technologies that keep us healthy. A few things are incubators for infants. Basically every neonatal intensive care unit has incubators for premature babies when they're born to keep their body temperature regulated, to keep them from getting infections, but this is something that a lot of developing world hospitals don't have. And so I'll tell you a little bit more about Rice 360, where I work. So we design these low-cost medical technologies and then design them so that they're appropriate for the healthcare settings that we work really closely with. And we get feedback from physicians, and we work really closely with hospitals in Malawi. We get feedback and design ideas, and then we present these ideas to the students, and they come up with these amazing technologies, and I'll talk a little more about them after. So yeah, here's one of the physicians in Malawi. This is it's a phototherapy light for babies with jaundice. They turn yellow. It's a really common disease in babies and easily treated with blue LED phototherapy lights. So this is a technology that some students designed with help from physicians at a hospital in Malawi. So we have two main focuses. First is pediatrics. I think the majority of the technologies I'll talk about are designed for babies' health. And then the second is point of care diagnostics. So it's really important that people in these low resource settings can get fast, cheap, easy ways to diagnose diseases such as HIV, such as anemia, STDs, other diseases, and we are presented very readily with these means of diagnosing, but they're often way too expensive to use in developing world hospitals. Okay, and then we involve students. So every summer we have internships where we send students to. Right now there are about 5 students in Malawi working at 2 different hospitals. So they take designs from the previous year, show them to physicians and get feedback, and then they also help physicians with anything that needs updating in the hospital. So sometimes they fix equipment, or they, this year they're helping with some trials that we're running for this device that I'll talk about. And there are 4 interns in Ethiopia that are working on medical inventory. So a big problem in a lot of hospitals is that medical technology is donated, but the hospitals don't end up using it either because it's broken or because they don't know how to use it, or just one part's broken. So there's usually a big room with a bunch of unused equipment. So some of the interns are just going through and marking off all the equipment, and so that the hospital can know exactly what they have. And these internships are paid completely by Beyond Traditional Borders, and you even get a stipend on them. So they're pretty cool. I never did one, but now I wish I had done one. Okay, so one of our first big technologies is called Dose Right. I'll pass it around. It's a set of syringe clips that you put into the syringe. You slide it into the plunger, and then it only allows you to pull up the correct amount of medication. So students designed this in their sophomore year of college, and it's primarily used for the delivery of HIV medication for infants. And so the mother then doesn't have to know, read exactly how much to deliver, and also these numbers wear off really easily. So the pharmacy just gives out the medication, the syringe, and the correct clip that goes along with it. And each clip is designated for a different volume. And so this was, I think, in 2010, and some students traveled to Swaziland the summer after it was designed, and one of them made really good connections with the Ministry of Health there, and then they asked for 200,000 packets of these dosing clips, and so we gave them to them, and they've asked for even more because they've had so much success with it. And they ended up going to Clinton Global Initiative University competition, and they won some money and got to meet Bill Clinton, which was pretty cool. Okay, and then our really exciting technology right now is CPAP. It's do you guys know the CPAP systems that are used when people have sleep apnea, when adults? They get this big system that they have to sleep with a mask, and it just helps them breathe. Yeah, so this is really similar. It basically delivers pressurized air to keep their lungs open so that they can keep breathing. And so for infants, especially premature infants, they have a lot of respiratory issues, and they just need a little help breathing. So this provides enough pressurized air to just get them to keep breathing so that they can use energy on other things like regulating their body temperature and fighting off infection and stuff. And so how it works is there are 2 aquarium pumps inside. So we're all about repurposing things, making it really cheap. And then the pressure is just created by this column of water. And so the prongs go into the baby's nostril and deliver pressurized air. And you can also hook up an oxygen concentrator to give them a little bigger boost. So right now, I have 2 coworkers who are living in Malawi working on this device, and they're right now driving to, well, eventually they'll have gone to 30 different hospitals, delivering about 4 to 5 of these to each hospital, and training the nurses how to use it, training technicians how to fix it if it breaks. And so we started out at a hospital called Queen Elizabeth Central Hospital, where we work really closely with, and this has been used for about a year there, and we've seen some really cool results. Like here's a picture of a baby on the CPAP system. This is an older generation. And this came from a senior design project like 3 years ago, and the student's still working on it. So in her senior design project, she came up with this system and it was in a shoebox. And then she got hired as in my position and continued to develop it, make it look a little more professional, because delivering something in a shoebox is a little scary looking. So then we're working with an industrial designer in California, and they came up with this system. But the insides are basically the same as what she developed in her senior year of college. And now she's living in Malawi, working on this, getting to see babies literally saved by the technology that she designed. Because you can see a very immediate effect when you put babies on CPAP. Babies who are having really a lot of trouble breathing and have low oxygen saturation in their blood, minutes after you put them on, you see them breathing more deeply and their oxygen saturation goes up. It's really cool. And this costs...
Terry, what's your question?
Yeah.
What do you mean by oxygen saturation?
So the amount of oxygen in their blood.
Oh.
Yeah, so it's supposed to be 90% or greater, but these babies, since they're not able to breathe as deeply and as much, they're not delivering oxygen throughout their body. So just with this, by keeping their lungs open, they're able to get more oxygen in and deliver it to all the cells in the body. Yeah, that answered your question?
Yeah, that answered my question.
Okay, cool. Yeah, does anyone else have any questions? No? Okay. Okay, so this is a project that Rachel and I worked on our senior year at Rice. And it's an apnea monitor for premature babies. Those babies gets lots of treatment, give it all sorts of things. So now it's wearing the apnea monitor. And what apnea is defined as when a baby stops breathing for 20 seconds or more. And it's really common in premature infants. And in the US, babies are hooked up to monitors that can tell if a baby stops breathing, and then nurses can go over and respond to the baby. But in many developing world hospitals and in the hospital we work with in Malawi, babies have no kind of monitoring. So, and there may be 2 nurses for 60 babies, and the wards get really crowded. So all the parents are there caring for their kids. So there's really no way for the nurses to tell if a baby stops breathing. It's really by luck. If they're wandering around and they notice that a baby's turned blue, then obviously the baby isn't breathing. So we're presented with this idea to design a low-cost apnea monitor, and we came up with a belt with a stretch sensor inside that changes resistance as the baby's chest expands with each breath. And we also included a vibration motor that turns on to stimulate the baby to breathe. Because the nurses, usually when they notice a baby has stopped breathing, they go over and pat the baby a little, just remind the baby to start breathing again. So these nurses are really overworked, so we thought, why not just include something that does that for the nurses? So we put a vibration motor in the belt, and we actually don't know how well that's going to work yet, but we were just approved to do clinical testing at Texas Children's Hospital and also at Rice University's daycare. So I will be working with lots of babies this summer and in the fall, which I'm really excited about. And eventually we will do clinical testing in Malawi, and I'm traveling there in the fall to kind of feel out how this apnea monitor can fit in to the hospital. So we had to learn how to program in C, which is something that we didn't learn and this kind of became our lives senior year. I loved this class a lot, and I wasn't expecting to continue working on it after my senior year, but this job popped up and they decided that they really liked this project. So now I'm getting paid to do something that I was paying for senior year. That's pretty cool. Okay, so I didn't bring this device, but it's a syringe pump, and it's based off of a metronome and gears and a loaded mass. So the syringe pump delivers the correct amount of fluid over a certain period of time. And it was developed for neonatal patients, for newborn patients. And so you put the syringe in here and you set the correct flow rate, the desired flow rate. So say you have a large 60 cc syringe and you want 15 milliliters per hour to be delivered to the patient. Then you move the metronome up to there, and it will tick at the correct flow rate, and with every gear turn, your mask comes down and presses down the syringe, and fluid is delivered to the baby. This was developed originally in a senior design engineering class, and then it was taken on by one of our summer interns that was working in Houston. And that was a few years ago, and now there's another senior design team that's working on a little more high-tech one, maybe for different settings, that uses some electricity, can be battery-powered or run off of the wall, and it just allows for more precise flow rates. So you can program in, maybe I want 60 or 30 milliliters per minute for the first 15 minutes, and then change to 30 milliliters per hour for the first 15 minutes, and then switch to 15 milliliters per hour, and it does it automatically for you. So you can put in a protocol, which is pretty cool. And then the last technology I'll talk about is called the SafePad. This was developed the same year that Rachel and I had our design project Apnea Monitor, and it's kind of based off of diapers. So diapers have this super absorbent polymer that absorbs, well, the urine that goes into diapers. But this is used to absorb blood. So it's put under the mother as she's delivering, or after she's delivering, and then the nurses can count the number of squares that have absorbed blood, and if 10 squares are fully saturated, then the nurse knows that the mother needs immediate attention, because this is the limit for postpartum hemorrhage, which can be life-threatening. And right now, the way that they measure it is they put a bag under the mother and try to guess how much blood has gone into the bag. So this senior team put a uniform amount of super absorbent polymer into each square, and so exactly 50 milliliters of blood saturates each square. So once one square has been saturated, then blood moves on to the next, so you can easily count how much blood has been absorbed. And they just started clinical testing at Bentop Hospital in Houston, which is really cool. Race 360 is just starting to really implement all these technologies. We had done so on a low scale before, but now we're really getting into clinical testing of the technologies and looking more at sustainability. Because in the past, students would design technologies, we'd bring them to hospitals and then kind of forget about them. But how much impact can that have? Not that much. So with this, we don't really know the market right now. It may be used here in the US because it's super cheap. It's In the US, they still use bags too to estimate blood loss. They also do blood tests, but that's not always super accurate. And then for CPAP, I mean, there will be 120 of these in Malawi by the end of the year, which is really cool. And then eventually we'll scale up probably to other countries in Africa. So this is a really exciting time for global health. People are putting a lot of effort and money into developing low cost and effective technologies that can be used in places that really have nothing. That's a picture of one of our students. I don't know where exactly, but she's carrying a diagnostic backpack, so it has a bunch of tests. It has a centrifuge, a microscope, and these can be used by community health workers. So yeah, that's all I have. If you guys have any questions.
How long did it take to develop that?
This one?
Yeah.
I think it's been 4 years since the senior design project, maybe 3. So it was pretty fast. Compared to industry, we output these really fast.
So you know how long like it would take normally? So if like Abbott Labs or Pfizer or something were to make this, how long would it be in
I
development?
could
do you think?
guess. I don't know. 10 years? Yeah. At least. And I mean, one of the things is that in Malawi, they don't have one medical regulation that you have to follow. So we have to work really closely with the Ministry of Health and base it off of other technologies that have been there. So they have nothing like the FDA, which if you go through the FDA, that will take 15, 20, 30 years. So, yeah. Any other questions? Do you guys want to tell me about your projects?
All right, thank you very much. You can go ahead and